So the next person I want to introduce, if Ontario's pain system had a project manager, her name would be Rachel Bosma. She's the glue between research, policy, and advocacy, helping build a pain care system that's smart, responsive, and equitable. She's the director at the University of Toronto Centre for the Study of Pain. She's the chair of Pain Ontario. She's a research scientist at the Toronto Academic Pain Medicine Institute. She is my work wife and a true connector of people and ideas. She's here to talk about transforming pain care into something that actually works for people. Please welcome the visionary, Dr. Rachel Bosma.
Thank you for that introduction, sweetie pie. All right. We need the right care at the right time in the right place. For chronic pain, the right care means options for care, and it's personalized. The right time spans the course of one's disease and the lifetime. The right place ensures access to care where you are, where you need it. But do we have it? Do we have the right care? We've heard today that we've come so far. We have new interventions and we are repurposing old. We have centers to study pain. We have guidelines. We even have a new national pain standard. But as far as we've come, we've heard that barriers still remain. The system wasn't made for everyone. Not everyone has access to care. The wait times are long, the services are not evenly distributed, and the barriers are not equal for everyone, especially women and Indigenous peoples. So if we're going to talk about the right care at the right time in the right place, we still have work to do. And we need to do this work because chronic pain, it's more than just big numbers. It's more than expenses, big expenses. It's more than statistics because those can be ignored, those can be overlooked, but we are talking about suffering. We are talking about people's lives, Vina's life, Kate's life, Graham's life, maybe your life, maybe the life of someone you love. And pain is everywhere. Emergency department visits. Unmanaged pain accounts for 15% of emergency department visits. So if we're going to talk about ending unnecessary emergency department visits, if we're going to talk about ending hallway medicine, we need to be talking about pain. Mental health and substance use health. These issues are they can be deeply intertwined with chronic pain. And I was so encouraged by the fireside chat that we heard earlier. Because if we're going to talk about mental health and improving mental health in this country, and we need to be, if we're going to talk about improving substance use health, then we need to be talking about chronic pain health. Disability. Pain is the leading cause of disability in this country, and it's a common outcome of work-related injuries. And I can keep going because the pain whack-a-moles, well, they just keep popping up, don't they? Pain is everywhere. So for the policymakers in the room, pain might not be your portfolio, but it's certainly causing you problems. Because pain is a cross-cutting issue, and it is a driver of many of the health issues that we are facing today. And it has a substantial impact on our workforce and on our economy to the tune of $40 billion a year. It's affecting the lives of people living in this country, and it's affecting the health of our communities. But the good news is that if pain is a driver of these issues, then appropriate pain care has the opportunity to be an enabler, a huge enabler for big health and big system change. And I'm here to tell you today about what we're already doing and what I think we need to continue to do and do better to improve the lives of those living with pain. So I'm going to use Ontario as an example, and I'm going to ask you to think back to 2014, 2015. So for the trainees in the room, you know, this was a lifetime ago. For everyone else, it was about 5 minutes ago. Think back to 2014, 2015. A young woman named Sophia was in a car accident. Her injuries healed, but her pain did not. In fact, it became her full-time job. Researching, scheduling appointments, going to appointments, looking for answers, nobody having answers. She felt so alone, isolated, unable to work, depression set in. She had nowhere to go. 2015, 2016, the Ontario Ministry of Health invested in interprofessional care across the province, across 5 pediatric hospitals, 13 adult hospitals, and 1 community clinic. This meant that patients like Sophia had somewhere to go for the first time. She had somewhere to go to receive psychotherapy to address her chronic pain and her depression. She had exercise-based programs where she could get moving again. She had reviews of her medication, and she was given options. She had a pathway forward. At around the same time, we built out e-consult for chronic pain so that specialists could connect with community providers and consult on chronic pain cases. We drove forward Project Echo Pain. So now we're bringing healthcare providers from across the province, all disciplines, around a table to discuss pain cases, to learn from each other and from experts, and to build capacity in the system. These programs are game changers. This is changing pain care in Ontario. But this is not the end of the story, because chronic pain is a chronic disease, and people will need different care, different solutions at different times over the course of their disease. And these pain clinics in the network, they cannot, they will not, they should not see the 1 in 5 facing chronic pain. Not over the course of their disease and not indefinitely. So where are these people going to go? Because they're going to go somewhere. Of course they are. They're experiencing pain. The next therapy, the next intervention, is it evidence-based? Primary care is the obvious solution. Right? Primary care is at the front lines here, forefront of chronic disease, chronic pain management. But we know that our primary care sector is in crisis. We know this. We, the collective we here, we are working to change this. We are working to improve access to primary care. But I challenge us to think beyond access, not beyond just names on a roster. I challenge us to think about building capacity for pain care in primary care, and to think about delivering services locally. And one key piece, a piece missing in Ontario, are community-based services. So here I'm thinking about care navigation. So if you're experiencing pain, you can pick up the phone or connect with somebody, and they can direct you to pain services in your area. They can direct you to pain education. They can direct you to the social supports that you may need. I'm thinking about peer support, because we've heard how isolating, how lonely chronic pain can be. And we know that peer support, when people come around and they share experiences, they create community. They validate the pain experience, and they empower people living with pain. These services do not need to be delivered in hospitals. They don't even need to be delivered in the doctor's office. But they need to be delivered somewhere. These services are essential. And other provinces, such as British Columbia through the work of Pain BC, have shown us that when we invest in community-based services, people's lives improve and the health system improves. And organizations like Pain Ontario are championing these efforts locally. We need coordinated pain services that help people, support people in pain across the course of their disease. so that patients like Sophia are not left stranded, that community-based services wrap around the support that they receive in primary care and in tertiary care, that they always have somewhere to go. 8 million Canadians, 3 million in this province, suffer from chronic pain, and these numbers are only getting bigger. So we need to think bigger. We are living in a chronic disease world with an acute care health system. So we need to go beyond incremental change. We need to go even beyond innovation, and we need to think transformation. We need pain scientists to continue to push the boundaries of innovation and discovery, because we need to understand pain better, and we need better options to treat it. We need pain services that extend from hospitals into communities. We need the right care at the right time in the right place. And when do we need it? And this is where you respond, now, because I'm prepping us for the parade later. Okay, now, thank you. We need them now, because we're at a precipice. We're headed for a cliff in terms of the pain crisis. But we're also at the edge of big solutions. So the question becomes, are we going to take what we know? Are we going to take what we've learned today, across this weekend and beyond? Are we going to take what we know? Are we going to take what we've learned? And are we going to do something? Thank you.
We have questions for you. We have questions. So many questions have come in for Rachel Bosma. Here's a couple. Let's go with the first one. You mentioned pain is a cross-cutting issue and a driver of many other issues. So why do you think pain is not getting the attention it deserves? That's the first question.
Yeah, thank you. That's a great question. And I think we touched on that theme today. I think it comes from our understanding, or rather lack of, and I don't mean us in this room, but when pain is only being recognized as a disease in its own right for the past 5 minutes, a couple years, right? It takes a while for that to trickle down. And we've also approached things like pain in silos. So it depends where you go in the health system to this date, right? If it was seen as just a symptom, as just a result, as Bev mentioned earlier, of something else, then you're always looking at the something else and you're not looking at pain. So I think that that's changing. I know that it's changing. Attention is being paid to this. We are understanding it. We're recognizing it as a disease. We're training the next generation of healthcare providers to see it as a disease and to understand it better. We're talking to mental health experts. We're talking to substance use health experts, and we're trying to break down these silos. But there's still work to be done.
And a second question, what is the most efficient way to build capacity, which I think you mentioned, in primary care for pain services?
Building capacity in primary care, yeah, it's a great question and it's a great opportunity. And I think the answer isn't obvious, because I think the obvious answer is just, they should just know it, they should just do it. But that seems to be our answer for everything in our healthcare system. So I think we need to look very closely at equipping our primary care sector. I think we need to be building out primary care teams that are interprofessional. So I think the question was the most obvious. I'm not giving the most obvious. I'm giving kind of a systems health answer. In Ontario, we're really working towards this. I think it's building capacity across disciplines. We've heard pain's complex. You saw Sean's slide. You didn't understand it. It was too busy. It's too complex, right? So we need different approaches. We need different voices in the room, so they need to be in those care settings with different scopes of practice. But I think, too, the obvious answer is we need to train our future providers about pain, and that it's a disease. There was this landmark study, it's older now, saying that, vets, right? We've heard this study, vets received X% more pain education than even physicians. And we've been working to change this, but the work's not done. So how are we training the future generation of care providers? How are we training them to understand pain, understanding their scope of practice and where their scope, kind of ends and where they need to tap on colleagues and how to do that? How are we training our future care providers to talk to the patients in front of them and to listen to them and to understand that for whatever reason they're coming in the room for, there might be more, right? They might be coming in the room for a different issue, but when you really listen, you can look for some of the drivers of other issues and address them holistically.
Thank you very much.